Good morning, everyone, and welcome to the Masonic Cancer Center seminar series. Joining us today from Rochester, New York is Dr. Supriya Mohile. Dr. Mohile is a professor in the Department of Medicine at the University of Rochester, New York. She's also the director of the Geriatric Oncology program at the Wilmot Cancer Center. She's a world-renowned geriatric oncologist, but I wanted to tell you two anecdotes about her. My co-fellow, Dr. Rami Sedhom, who's now at the University of Pennsylvania, during our first year of oncology fellowship, he was very interested in geriatric oncology. And he came to me with a research idea, and I said, dude, I have no idea about this. Just email someone. And he ended up reaching out to Dr. Mohile, who was and is the editor-in-chief of the Journal of Geriatric Oncology. And she replied very warmly about this new series that he wanted to start, and it actually took off. She loves to mentor, has tons of mentees who've all been very successful. And in fact, she's decided to donate her honorarium for this talk to the Fellows Research Fund. So we're very, very excited to host Dr. Mohile. For this talk, she'll be talking for maybe 55 minutes with 5 minutes for questions at the end or so. If you could please write them in the chat or in the Q&A or raise your hand up at the end of the talk, we'll give you a chance to speak. Thank you so much, and welcome, Dr. Mohile.
Thank you. It's really wonderful to be here and also to be invited by Dr. Gupta because I've been following his research for many years and reading it, and I think he's doing wonderful work in value-based care. And so we are aligned in trying to figure out ways to improve value for patients with cancer, especially those with advanced cancer, who have difficult decisions to make about treatment and have to weigh risks and benefits in shared decision-making methods with clinicians to try to figure out what the best choice is for them. And it can be very difficult for vulnerable patients, especially those who are older. So as Dr. Gupta mentioned, I am at the University of Rochester, and I have a few leadership roles, including leading our Geriatric Oncology Research Group, and I lead the National Cancer and Aging Group Research Group with Dr. Dale from City of Hope and Dr. Kleppen from Wake Forest. That's funded by the NIA. So that's a resource, which I'll talk about a little bit for anybody who's interested in geriatric oncology. In addition, I am the editor-in-chief for the Journal of Geriatric Oncology, and I lead our cancer control and prevention program at Wilmot. So I will talk today about my work and some clinical trials about improving outcomes for older adults with cancer and their caregivers. So why is this important? And I was talking to Dr. Gupta earlier today about his clinic in GI, and he said about half of the patients that he's been seeing are age 65 and over. And I think we know this. The epidemiology is very clear that cancer and aging go together, and that the majority of patients with cancer are older than the age of 65. Much of the public focus has been on younger patients and middle-aged patients, and our clinical trials have focused on middle-aged patients and younger patients, which creates a gap because we're not getting safety and efficacy data of treatments for older adults as much as we should, given the high prevalence of disease in older adults. Here's a study from that we looked at aging, and I think what strikes me too is that the subgroup of patients with cancer that's growing the most in terms of numbers are those age 75 and older, and especially those age 80 and older. And in my geriatric oncology clinic, almost all of my patients are 80 and over. And I think that creates a very unique and situation that offers us opportunities to be better in what we do in terms of care delivery. And we've been thinking about this for a long time. This is work by ASCO, American Society of Clinical Oncology, Laura Levitt, and then leaders in the field, including my mentor, Dr. Arti Huriya, who I will honor her throughout the talk because she taught me so much. She unfortunately passed away in a car accident in 2018 and was a few years older than me, but much of the work that led to my work, it was her mentorship. And so I tried to become a mentor like her, and that sort of drives me in my career. But she and others led an IOM report in 2013. This is the Institute of Medicine, now National Academies of Science, that talked about delivering high quality cancer care. And what they found was that there's a critical need for research in older adults, that there should be incentivization for requiring research in older adults, and that we need to do better about research design and infrastructure, recruitment of older adults, and reporting of results from trials to address the needs, the data that would be applicable to older adults. And then this was published in JAMA. So this is not new. These questions have been around and has been going on for many years. So I will talk today just to educate about the ASCO guidelines. The ASCO guidelines were published in 2018, and they're in progress for being updated. Actually, a draft is out of an update to the guidelines that incorporate some of the randomized controlled data, trial data that I will talk about today. And then I will go through some of the RCTs that I have led to show that geriatric assessment improves outcomes. And then I always like, Dr. Gupta is doing mixed methods research. So what mixed methods research is, it's incorporating the patient voice through qualitative analysis of discussions, through interviews or focus groups, with quantitative data, either through surveys or outcome-based data from trials, for example, or from the healthcare research, so integrating that to really understand about experience and preferences. So as I mentioned, many of our patients are older in the clinic, and so this is a patient of mine who served on our scoreboard, which is our patient advisory group that kind of guides my research that I do in Rochester. And so he needed assistance with daily livings, had multiple comorbidities, mild cognitive impairment, limited social support. He lived alone, needed transportation issues, polypharmacy, and had frailty. And his daughter, it was his care partner, didn't live with him, is a nurse, but has a diagnosis of cancer herself and was going through treatment. So patients like this one do not participate in registration and cooperative group trials because there's lots of barriers, not just in exclusion criteria for trials, but also in barriers for this patient to actually get to the clinic and enroll onto a trial and then participate in all of the activities for a trial. He had curative intent rectal cancer, and I was not able to give him full treatment as per evidence in NCCN guidelines at the time, or ASCO. Now with some of these trials looking at de-escalation of therapy, I think he could have been, he could benefit from those, could have benefited from those trials. But the trials that were available were adding on one treatment to sort of control group, which you couldn't tolerate based on some of the tools that I was using. And so we adapted treatment, and he did very well. His outcome of interest was being able to ride his lawnmower each day. And so it's winter, it wasn't winter in Rochester when he was getting treatment, but he was able to ride his lawnmower on most days. And that was very important to him. And we used that to make sure he was tolerating whatever treatment he was on at the time. He completed treatment and then was cured. But I adapted the treatment with my clinical judgment. It was not evidence-based from a trial. And given my geriatrics background, maybe I can do this a little bit better. Maybe I can't. But when we think about all the clinicians out there who are sort of making up or subjectively adapting treatment, it leads to variability in treatment allocation, as what we see in population-based data sets like SEER. And so we need to have better evidence-based standards that we're doing for older adults, not just those who are younger and middle-aged. Geriatric assessment can help us with that. So what is geriatric assessment? It is an approach to the evaluation for an older patient, leading to early identification and treatment of areas of vulnerability. The geriatric assessment evaluates aging-related domains that are listed here. And each of these domains are independent predictors of morbidity and mortality in older patients who are community dwelling. So older patients with cancer are older patients, and they have all the kind of physiologic issues and concerns that any older patient would have, but then they have cancer too. And so that's sort of a multi-morbidity framework of keeping the cancer in context of other aging-related conditions. We now know that each of these domains are predicting cancer outcomes also, and because we've been able to do studies to look at that. And I'll talk about the difference between the domains and the tests we use to measure those domains. But this may be a toolbox, because it's been developed by geriatrics, that helps us really guide decisions in an area of uncertainty, because we don't have data about safety and efficacy for vulnerable and for older adults. We need objective tools to help us come up with the best decisions, not just a physician's eyeball test or clinical judgment, which can be variable. So why consider geriatric assessment? Geriatric assessment captures clinically important issues that go undetected. It can identify older adults who are at high risk for adverse outcomes. And I'll show you through randomized controlled trials that we have led that geriatric assessment can improve communication and decision-making. So one of the first tools that we used, and I know Dr. Gupta and Dr. Blaze and others are looking at this tool in some work they're doing at University of Minnesota. But this is one of the first tools we did, and we did it with Dr. Huria through one of her K Awards, where we were trying to take variables from the geriatric assessment and to assess if capturing some of these variables could help us identify patients at risk for a serious toxicity from treatment. And it was a pretty kind of low resource study. It was a bunch of early career investigators, and we basically did geriatric assessment before patients started a new treatment. We collected toxicity information, and then we looked at what predicted that toxicity. And what we found was that some of the variables that we normally kind of collect and consider in oncology care also, predicted outcome, which was not surprising. So age, what type of cancer a patient had, GI cancers being very chemotherapy heavy, standard dose chemotherapy, multiple agent chemotherapy, anemia, and creatinine clearance predicted outcome. But there were variables from the geriatric assessment that also predicted toxicity, and this included recent falls, hearing impairment, limitations to walking a block, needing assistance with medications, and having social activities that were decreased due to health. And many of these questions we're collecting better now. Actually, our nursing colleagues collect these way better than physician clinicians do, including the fall information. But do we actually use this information in clinical decision-making? That I think is happening less. And so some of the geriatric assessment trials show how to do this a little bit better. The Cancer and Aging Research Group has a website, and the CARG tool is available on this website, as is a more full geriatric assessment. So after my talk today, if you want to do more of this work, you can pull up the CARG website and then in the clinic kind of use it if it makes sense to you. And we are seeing that the tools are being used very commonly across the world now. In fact, I had during COVID, a visiting professor from Japan who does clinical trial work in lung cancer in Japan. And the CARG tool was embedded in a trial. And while she was here, the CARG website crashed, and her colleagues who are oncologists all over Japan were calling her emergently because they wanted to enroll patients onto her trial. So we had to get it fixed really rapidly. But I think that really struck me as how much people are using this website across the world. So that trial, that tool and others informed the ASCO guidelines, which were published in 2018. And I want to comment first on how rigorous ASCO guidelines are developed. So ASCO staff do a very robust literature search. And in this ASCO guidelines, we reviewed 60 studies that were high quality prospective observational studies of more than 100 patients across cancer types. And at the time, there weren't many RCTs, but whatever was available, we reviewed. And we reviewed it as a panel. The panel includes community oncologists and academic oncologists who are not geriatric oncologists, as well as PhD scientists and patient advocates. And we put the guideline together, and then it's reviewed again by the ASCO guideline committee, and then also by the Journal of Clinical Oncology reviewers. So if it wasn't sort of sound in strength, in quality, and didn't make sense, it wouldn't pass those different levels. So I find it, surprising still when people are kind of concerned about the evidence for geriatric assessment and maybe question it when these ASCO guidelines kind of fly through. And we are doing one for that kind of updates the RCT data now that should come out within the next 6 or 8 months. So the ASCO guideline addressed several questions. Should geriatric assessment be used for older adults with cancer? We focused on chemotherapy because of the CARG tool. Also, there's another tool out of Moffitt called the CRASH tool. And a lot of the studies at the time, this is prior to 2018, focused on chemotherapy outcomes. There is a robust literature in surgery, and now we're starting to see more in immunotherapy and targeted agents, but at the time there wasn't. And the new ASCO guidelines will address other systemic treatments. If older adults are getting chemotherapy, which tools should we use? For those for curative intent, which I'm not going to focus on today because my studies are in advanced cancer setting, what tools should we use to evaluate life expectancy unrelated to the cancer to understand if treatment makes sense if someone has to short life expectancy, for example? I often use e-prognosis for patients that have small kidney masses, for example. Should a patient go through a big operation that might lead to more renal impairment, if they only have, a 2-year life expectancy estimation due to other comorbidities, it may not make sense to that patient. And then how should geriatric assessment be used in management? So in terms of should geriatric assessment be used, the strength of the quality was very high and the strength of the evidence was very strong. Which tool to use wasn't as strong in the evidence because we don't have head-to-head comparisons about the different tools. But the panel put together a tool minimum data set or a toolbox, which is being adopted in the new guidelines. If you do this minimum data set, it takes less than 10 minutes and it does not have to be done by the physician. And I'll talk about some implementation work that we're doing to try to figure out who in the clinic may be most appropriate to do some of these tests. In my clinic, I do not do the geriatric assessment myself. My team does it, and we do different parts of it. And then when I sit down looking at a new patient's information from the chart, the available kind of scores and the tools are available to me at the same time because we've sort of organized the team flow to be able to manage this. So thinking through the minimum data set, the Tox tool, as I mentioned, IADLs, which is the ability to care for oneself in a community setting. This is instrumental activities of daily living, very predictive of an outcome across studies. And if there's any patient-reported outcome to do for older adults, this is probably the one. Comorbidity, we do very well in our clinic. We have very long problem lists. And so we don't really need to do additional work related to comorbidity. And that is true of nutrition too, because we're collecting weight loss information and BMI information as part of what we do in the clinic. One question for falls: have you fallen in the last 6 months? And then we do recommend validated tools for depression, which fits in ASCO guidelines. We use the geriatric depression scale. However, if you're doing PROMIS, that fits. If you're doing PHQ-2, that fits. So a lot of patient-reported outcomes that are already being integrated in healthcare systems would be fine. And then what we don't do for older adults, which is a show from my RCT data, is very important, is cognitive screening. So MiniCog is a great tool to use, or the Blessed, but using a very objective way to assess cognition is important. In our trials, before we developed our trials, we were really thinking about management recommendations and clinical process guidelines. And so I didn't have a great way of looking at creating an intervention. So what we did was really interview geriatric oncology clinical experts across the country. And what they told us is that we had to really evaluate each of these domains independently because each of them are important to outcome. I tried to reduce the number of domains and they said, no. Each of these are important for outcomes, so you have to evaluate them. However, which test we used, which is this middle column, was up to the clinician and the resource setting. And so there's different resources available. In my clinic, we can do very standard objective physical tests that take a few additional minutes, like the timed up and go or the short physical performance battery, but not all clinics can do that. And so maybe thinking through a quick patient-reported outcome like IADLs and asking about physical health, maybe what that clinic can do. And so adapting to resource setting is perfectly fine as long as those ASCO guidelines are met with the important outcomes or the important tools and domains to assess. And then in terms of what to do with the results, we can use the results to impact our cancer treatment decisions, but we can also use them to guide process outcomes. And so, for example, I'm going to oh, I didn't have it in there. So let me go back here. For example, for functional status, if there's an impairment on an instrumental activity of daily living, that could lead to an algorithmic intervention where PT is organized, safety eval is organized, people are getting education for fall risk prevention, people are getting prescriptions for exercise, and that could be built into the electronic record, or you could have a separate visit. In our clinics, advanced practice practitioners are running these geriatric assessment visits as long as there's not a specific cancer treatment recommendation, which would often require an oncologist input, but they're sort of doing the supportive care and survivorship care related to geriatric assessment themselves using the algorithms. And so that will increase the ability for this older adult to get aging sensitive care in real time. In the ASCO guideline, they have a section on communication for all ASCO guidelines, and this is what was proposed for the geriatric oncology guidelines. In my clinic, using a geriatric assessment opens up conversations about goals, about preferences, and about what patients want, and helps us weigh risks and benefits of treatment in situations where it's uncertain for what to do next. And so concerns that the patient has about memory, about other medicines, about how cancer treatment may impact their overall health are addressed. And then, and also we can use that to improve outcomes. So one of my first RCTs was really looking at these patient-centered communication outcomes that I just highlighted is addressed in the ASCO guidelines. And this was funded by the Patient-Centered Outcomes Research Institute and was conducted in a national setting through the NCI Community Oncology Research Program, or NCORE. Our goal was to see if geriatric assessment could improve communication about aging. And so these are concerns that patients tell us they had, but they didn't know were important to an oncology clinical care setting. And also that caregivers had, for example, can mom live independently? Do we need to put more support in the home for dad with his medicines? These are concerns that families have that don't always come up when we're doing chemo teaching, because they're not always sure that it makes sense to talk about unless we directly address those concerns. And so as outcomes, we measured direct communication by audio recording clinic visits, and we also looked at patient and caregiver satisfaction. And our hypothesis was that providing assessment results has the potential to improve communication. We did this again through the NCORE, which is our NCI Community Oncology Research Program. We are lucky enough to have a research base at the University of Rochester. Most of them are in our cooperative groups. For example, Alliance has one, SWOG has one, ECOG has one, but there's two at institutions, one at U of R and one at Wake Forest. And so we're smaller and a little bit more nimble to do complex and are able to do complex care delivery intervention studies in a phase 3 setting like this, like we were for the 2 trials I'm going to present. I want to highlight that our intervention was very low touch and low resource. Basically, we gave the clinicians a checklist for what to do about communication and recommendations for management, which I'll show in my next trial, but they got the same intervention in both trials. And so if a patient had cognitive impairment, the clinicians would get this checklist. Think about discussing the patient concerns about memory, eliciting the caregiver input, assessing capacity, which is really important for someone with cognitive impairment. I see all the time older adults signing RAD-ONC consents, chemo consents, and when we see them, it's clear, it's not clear, but after talking to them and knowing that they screen as impaired on our tools, that they don't have capacity to make an informed decision. And so in that situation, there has to be a healthcare proxy on file for our protection and for the patient's protection, and that we have to have that on file. So we were able to increase those outcomes through this trial. And again, on paper, we handed it to the oncologist. They could have thrown it into the garbage, really. It was really up to them what they wanted to do with the intervention. The study was cluster randomized, meaning practices across the country were randomized. It wasn't patient randomization. The intervention was very low touch and low resource in that the summary was given to the clinicians for each patient enrolled onto the trial at the intervention sites. And then the practices that weren't randomized to intervention were usual care. The patients completed geriatric assessment, and only serious cognitive impairment and serious depression were communicated to those clinicians. And we evaluated, as I said, satisfaction, communication, and other outcomes. We enrolled patients that are routinely not enrolled in clinical trials because we thought that this communication is so important for patients for whom evidence is limited. So we enrolled patients over the age of 70 with advanced solid tumor malignancy or lymphoma and curable cancer. And we enrolled patients that had one or more geriatric assessment domain impairments other than polypharmacy. And we excluded polypharmacy from that definition because so many older adults have polypharmacy, and we would have just enrolled everyone then, but we wanted the most vulnerable patients. And so patients who had a functional deficit, for example, cognitive deficit, they were enrolled in. Patients were able to choose one care partner to enroll, and the caregivers also gave caregiver reported outcomes at each of the time points that the patient provided information, so we could really evaluate the caregiver experience during the trial. This was pre-COVID, but we were able to enroll 305 oncologists, 541 patients, and 414 caregivers through the course of the study. And I think it was really well liked by our community oncology practices, because it addressed a question that the older adults cared about. And so we learned from each of these different enrollee groups. And so I'll kind of go through the data for each of the groups. What did we learn from oncologists? Well, prior to enrolling, or at the time of enrollment, we did a survey with oncologists. And community oncologists believe that medical care for older adults with cancer needs to be improved. 89% said they did. However, very few were using standardized geriatric assessment tools. 23% were. And I actually thought that was pretty high given the time that this trial started in 2014. Many wanted additional training, which is why I always start with ASCO guidelines during the talks I give. And they may want more granular training related to fall prevention, related to cognition assessment. That isn't provided routinely in fellowship training, and maybe isn't provided as we care for adults through our training in general, as or sort of ongoing continuing training as clinicians. And so really there was a need here that oncologists recognized. What did we learn from patients? Well, the patients in this trial were all receiving treatment, different kinds of treatments. The geriatric assessment wasn't timed for treatment. However, patients on treatment had very high prevalence of domain impairments. Over 90% had physical performance impairments. A third had cognitive impairments. They screened positive for cognitive impairment. A quarter had significant depression or anxiety. The median number of domain impairments was 4.5, which was very high, much higher than I expected. Yes, there's a selection bias in that we're enrolling vulnerable patients, but it was a very, very frail population receiving treatment in community oncology clinics, which I was quite surprised about. But I was pleased that we were able to enroll these patients on a trial. These are patients who are historically very sick and very difficult to enroll onto trials. In terms of outcomes, we found that geriatric assessment improved both patient and caregiver satisfaction using a validated tool called the Healthcare Climate Questionnaire. So this, and the value persisted up to 3 months after the one-time intervention we did compared to usual care. So when people kind of come to me and say, patients don't want to do this, it's too burdensome for them to fill out all these questionnaires, it takes up too much time. When we look at this and we actually use the results to inform clinical decision-making, we communicate that to patients and caregivers, they get it. And they actually want to do it. And I've had patients tell me, nobody's ever asked me these questions before. These are really important for us to know. And I think this was reflected in these outcomes that we were able to analyze. And we also looked at, in the clinic, what actually happened with the conversations. Well, there were more conversations about aging, they were higher quality, and they led to more interventions in this trial. So not only did we improve patient caregiver outcomes, what actually happened, even though we didn't kind of tell oncologists they had to do anything, we just gave them the kind of checklist, they actually did use it in the clinic because they found it valuable, and it kind of guided care delivery. We're looking now with mentees about different domains, and this is being found, sort of the benefits are being found across the domains. So when we look at physical and functional performance conversations, the geriatric assessment improved conversations. We look at comorbidities, the geriatric assessment improved conversations. And for example, for comorbidities, things like eyesight, which we don't normally talk about that much, but can affect fall risk, et cetera. Those were more discussed and intervened upon in a clinical setting for patients receiving treatment. I'll pause now to talk about our patient stakeholder group. So we had a robust stakeholder group. Here are some of the members, and we published our engagement with patients and stakeholders in this paper by Dr. Gilmore in Cancer. It's really a pleasure for me to work with patients and caregivers, and we have a meeting still every month that's now led by CARG. And as a researcher, or a clinician, you can come to Scoreboard for free. You could just have to put in a query into the CARG website and talk to our patients and caregivers, and they'll give you very solid feedback on what you're doing. But they really enjoy partnering with us. So if you have the ability to work with patient stakeholders, I think it really adds value to the research research process. When I was done with the first publication, I asked them, the group, like, what should I look at next? I have all this data. I don't know how to organize it. And they said, you have to look at the caregiver data. So that's what I did. And when we think about caregivers, we know the public really cares about care partners and caregivers. This is a news article in the New York Times looking at an older adult with an older spouse and having that older spouse really provide the caregiving. She may have her own medical needs. How are her needs being met in this caregiving? And while this patient may or may not have had cancer, we see this so much in the cancer. If you walk through waiting rooms at any cancer clinic, you'll see couples like this. And so we don't do a good job of really hearing the caregiver voice. And so part of what we want to do moving forward is doing dyadic interventions that incorporate the caregiver. When we looked at our caregiver outcomes, caregivers were highly distressed. 44% had distress scores over 4, and a quarter had distress scores over 7. They had their own comorbidities, the majority being older spouses. A quarter were anxious and 20% were depressed. And when we thought about geriatric assessment and how geriatric assessment might help the caregivers, in the patients that had more domain impairment, so 1, 2, 3, 4 domain impairments, that the number of domain impairments increased adverse outcomes in the caregiver, both emotional health outcomes and quality of life outcomes. And that makes sense. The sicker the patient is, the more burdened the caregiver is. And so in my clinic, when I'm seeing an older patient and care partner, and I do the geriatric assessment, if there's a lot of domain impairments, I make sure I'm turning to the caregiver and I'm asking about their emotional health and their quality of life. If there's no time in that visit, our team is calling that caregiver up, and we're linking that caregiver to the social worker, and I do it at the next visit because that caregiver is distressed. And this sort of excerpt from one of the usual care clinic notes kind of talks about, points the caregiver shows how the caregivers are being distressed. Caregivers don't come to us and say we're distressed. They want to talk about the patient. They're there for the patient. They love and are caring for the patient. So it's hard for them to talk about themselves. And I think lots of us have been in caregiving roles and we feel the same way. But in this situation, it's a male caregiver saying she's been spending a lot of time in bed lately. She's not able to stand. The oncologist says, I see. The caregiver says she's in a wheelchair. She's not walking. The patient says, well, I want to go dance. The oncologist says, well, are you taking your pain medicine? So I see missed opportunities here. There are missed opportunities in sort of the rapid decline the patient's having and how the caregiver is being able to manage that at home. I also see some goals and preferences here. Is it realistic for this patient to be able to dance? And what are we doing with the treatment? And then obviously the oncologist feels more comfortable with the symptom management, and so is shifting to that. But there are lots of open opportunities here to talk about outcomes. So we've looked at social determinants of health in addition using the coach data set, financial toxicity, and I know Dr. Gupta's done quite a bit of work on this, is very important. And this came out also in a lot of the conversations about how older adults, for not just the treatment, but for supportive care, are making real life-changing decisions to balance the payments. And so someone here said, did you pick up your Zofran? And do you have issues of co-pays? Somebody else said, I need to pay for gas. I don't have money to pay for gas, and so I can't get those medicines. And so patients are making choices about what they do, and those choices can impact access and outcomes. And so thinking through financial toxicity in this population on older adults who have often strict kind of very strict money coming in the door through what they're receiving is really important. And then I'll just comment on Dr. Gupta's work in the Journal of Geriatric Oncology, looking at the costs of medicines that are coming out into the field. You know, medicines are getting more and more expensive, especially our oral medicines. And again, we're not often looking at the oral medicines and the copays related to that as costs that we can perceive in terms of choices that patients make. And it's really, as we all know, it's really hard for patients with limited income to be able to manage these very expensive meds. And we're going to the companies. It's a lot of burden on the clinics too, and trying to make sure that the patients can access these drugs that are often life-saving now. So I'll move to the next trial, looking at clinical outcomes. So even though that JAMA Onc paper, which the COACH trial was published in, was out first, lots of clinicians came to me and said, well, we know that patients are happier potentially with geriatric assessment, but we really need to look at clinical outcomes because that's how maybe we'll do it more, or that's how maybe reimbursement will kind of change for us to be able to do it more. And so we had a parallel study that was also done in NCORE, funded by an NCI R01, to look at if geriatric assessment improved toxicity. Remember, in that CARD study, we saw that geriatric assessment variables were able to identify older adults at highest risk for toxicity. Now, using the model we developed, we're looking to see if it actually could improve toxicity. And we also looked at other clinical outcomes like survival and treatment decisions. Our primary outcome was clinician rated toxicity as measured by the common terminology criteria for adverse events, which we use in all clinical trials. And so we're looking at clinician rated toxicity as the primary outcome. Again, looking at the intervention, both COACH and GAP, this is the GAP study, the same intervention. If a patient had physical performance deficits, the clinician would get like a paper, like low resource paper thing that said, here's why physical performance isn't really important. Here's why falls are really important. Here's your patient scores. And in addition to the communication about functional status that I showed, related to cognition, they also got management recommendations here that were derived from the geriatrics literature. Your patient is falling. Think about PT, think about occupational therapy, think about a personal emergency response system, which I don't think there's evidence for if you look at an RCT, but I will say anecdotally, I've had lots of patients fall at home and not be able to get to a phone when they're getting chemotherapy because of imbalance and the chemotherapy being neurotoxic. And that is just a very, very horrible thing to happen to patients. So PERS can allow a patient to call for help. And we do this for any older adult who is receiving chemotherapy, who is going to be alone at any given time during the day. We explain this in the clinic. Again, it's cluster randomized. So we randomize the sites in NCORE and very low touch, low resource intervention where they receive the summary and the list of interventions. We didn't tell them they had to do all of the interventions. We told them they could do what made most sense for the patient. Again, they could have thrown the whole packet in the garbage, but I think because of our outcomes, oncologists found value in the results and they actually used it in clinical care. Our primary outcome was met, and I think in a very robust way. So if we look at these results, the geriatric assessment reduced risk significantly of a serious toxicity for older adults receiving a new agent or chemotherapy. Adjusted risk ratio being 0.74, this was highly significant. If we look at it in another way, in the usual care arm, about 72% of patients had a serious toxicity. In the intervention arm, only 50% did. And so if you were an older adult getting chemotherapy, would you want to be in the usual care arm or would you want to be in the intervention arm here? I wouldn't want as much toxicity in advanced cancer where it's palliative treatment, and I'm not sure that it even makes sense given my frailty. And so here's where these results are really important to consider for older adults. I think non-hematologic toxicity was most affected. So these are toxicities that really affect symptoms like fatigue, diarrhea, vomiting, et cetera, more than hematologic toxicities. I will talk about the mechanism in the next slide, but one of the things that my clinician colleagues were concerned about with a geriatric assessment intervention is if they got information about frailty and reduced the dose, that perhaps the patient wasn't going to achieve the same cancer outcomes in the trials with relationship to survivorship, because we're being a little bit more gentle with treatment. We did not find that in this trial. In this trial, in both arms, survival was not changed. And so we're lowering toxicity without hurting survival outcomes. And how did it work? Well, in addition to the management recommendations, which I showed, so more supportive care interventions, there was also decision-making changes. So in a geriatrics, one of our geriatrics mantras are to start low and go slow with treatment. And unfortunately, the doses that we use for chemotherapy were derived in early phase trials that were not done in older patients with aging-related conditions. So we're guessing with dosing in this population. What happened in the intervention arm was more oncologists reduced dosing in cycle 1 when they saw that their patient had vulnerabilities and frailties. And so the intensity in cycle 1 was lower. However, in the usual care arm, they did it in a more traditional way where patients had toxicity and then the dose was reduced. Overall, the relative dose intensity of the two arms was very similar, maybe just slightly lower in the intervention arm, but that did not translate to a survival difference. So I would argue that older adults who are more frail have lower physiologic reserve, and we shouldn't be giving them toxicity if we can help it up front and then reducing treatment. We should try to prevent toxicity by being more careful with cycle 1 dosing. In addition to improving toxicity outcomes, we also improved some geriatric outcomes. So as I've sort of been focusing on falls. Falls are a very difficult and adverse outcome that older adults experience. And this trial showed benefits in fall risk. So in the intervention arm, only 12% of patients had a new fall, which I think still is a lot. So more than 1 out of 10 patients had a new fall within 3 months of starting treatment. But in the usual care arm, 20% did. So we're seeing a big difference in fall outcomes for the geriatric assessment. This may be due to lower treatment intensity, but also due to fall prevention and other PT and other supportive care interventions that were implemented. And so just putting this in context with other trials that are out there. So I talked about my 2 trials at the top, GAP and COACH. There's a trial called the GAIN trial that was done out of City of Hope, led by Dr. Huria, completed by the team at City of Hope. And that was positive for toxicity outcomes like the GAP trial was. There's a trial in Australia that looked at more longitudinally at geriatric assessment that was positive for quality of life. Recently, there was one negative trial published in Journal of Clinical Oncology. And this was a trial that was very difficult to do because it was during COVID. And so when you look at those results, they had trouble with people coming in and kind of getting the treatment, the intervention as allocated because of COVID. So that may have led to it, but we've got really quite strong data now across different outcomes for geriatric assessment. As a next step, we're looking at survivorship, and I've sort of talked more about survivorship in other settings, although I think the NCI and others are moving towards survivorship being important also for patients with advanced cancer. There's funding mechanisms out there now for this. And so I truly believe geriatric assessment in conjunction with sort of other survivorship education can improve outcomes because it's very aging sensitive. And we have an ENCORE trial now just getting off the ground, looking at advanced practice practitioners using geriatric assessment to improve functional and cognitive outcomes after chemotherapy for cancer survivors who are older. And then here's our aims related to that. So this GEMS study looking at patient-reported physical function, and then looking at cognitive function, both objective and patient-reported. And the reason why this is important is for survivorship, we're really thinking about care models and engaging survivors and caregivers as part of the team. When older survivors and care partners know about geriatric assessment, they want to do this. I know this from my group. I know this from public engagement. And so what we're hoping now is that patients are asking clinicians for geriatric assessment as they become more aware of what's important in terms of outcomes. And so geriatric assessment, I believe, can help tailor survivorship engagement, both nutrition, exercise, surveillance in patients who are older and more frail. The next line of research is implementation. And so one of the reasons I talk about the ASCO guidelines is that we know that many people are not aware of the ASCO guidelines. And when clinicians are not aware of the ASCO guidelines, they're less likely to do geriatric assessment in the clinic. So I always start with the ASCO guidelines during my talks. We also know, as I pointed out with some of the data I showed from the COACH trial, that oncologists want more education. And this is a paper done by Dr. Dale in JOP that really looked at the different domains and the implementation related to awareness of the ASCO guidelines for those domains. As a follow-up to the PCORI study, I'm working with an implementation scientist at MD Anderson, Dr. Lisa Lowenstein, to look at implementing geriatric assessment in the real world. So in both the COACH and GAP trials, they had NCI support. So it's not a pragmatic study that's done in the real world. Those are efficacy studies. We're now looking in the real world. Can we implement geriatric assessment with resources that are already available in the clinic, recognizing that resources are different across different settings? We're looking at effectiveness of geriatric assessment and whether or not our implementation strategies facilitate adoption. We're working with an organization called ACCC, which you may be aware of, and anything that we develop in this PCORI will be adopted by ACCC, and that will be available to all the whole network of community oncology sites affiliated with ACCC. What are we doing? Well, we're visiting sites and we're looking at workflow. And just being at a few of these sites, for example, in South Carolina, clinics that are very close to one another have very different workflows. In one site, patients are sitting outside in the waiting room, waiting to be roomed for a long period of time. There's an opportunity to do the patient-reported outcomes right there. At another site, the MAs, they have more MAs there, and the MAs were able to room the patients very quickly, but then they were waiting for the APPs and the oncology clinicians to come in. So the patient-reported outcomes should be done in the clinic in that setting. In addition, the MAs being more available there could do the mini-cog and could do the GDS. And so the MAs in our clinics here in rural practices in Rochester are very engaged, and they're actually wanting to be trained to do mini-cog and GDS, or the G8, which is a short screening tool, and give that to the clinician. And so, but that's not true of my tertiary care centers here. It's true of the rural cancer centers. And tertiary care centers, the MAs are not very tied to the team as they are at the rural cancer centers. So very different workflows and implementation strategies based on setting. And we hope that this will help us overcome barriers. It takes too long, it's too much time, slowing down the clinic, lack of staff that have been communicated to us, despite the fact that this is really people time, and people time is less costly than all of the other things that we do, biopsies, PET scans, personalized medicine approaches. I think the burden of trying to get a personalized medicine genetic approach done with paperwork takes more time than it does to do geriatric assessment per ASCO guidelines. So where are the resources to you? CARG is a big resource. ASCO is a big resource. So CARG is really a research resource, but there is a clinical implementation core. So if you have a champion in your clinic who wants to do geriatric assessment, you can sign up for free to the clinical implementation core, talk about your plan, and they'll give you feedback. We also like early career investigators, trainees to come on and to be available and hear from us. We have calls every other Tuesday at 2 p.m. And we're very invested with NIH, who will come on our calls and listen in. And that helps, I think, drive policy at the NIH. And it's funded, as I mentioned, through an NIA grant. And we have cores that are free, biostatistics core, supportive care core, health services research core that can provide you input. We've been very successful at writing letters of support for grants for people who are using our cores. NIH appreciates that use because they're funding us. And so sort of thinking about use of the infrastructure for grants related to older adults is a great use of our infrastructure. This may be my last content slide, but I'll sort of end with this framework of tolerability that we talked about in the Journal of Clinical Oncology and was developed by my colleague, who's a nurse investigator, Dr. Marie Flannery. thinking about all the comprehensive things that we have to think about. And I think this is what we try to do in clinical care, but it's also useful in clinical trials and longitudinal studies, because we can't really take out any of these kind of columns. It's all very important to patients. So aging-related conditions, social determinants of health, what type of cancer and treatment a patient's getting, and where's the data for that, and how we measure outcomes of tolerability through clinician-rated toxicity, through patient-reported outcomes, through functional measures across the cancer spectrum. And so this kind of comprehensively incorporates many of the outcomes I talked about. And I'll end with a quote from my mentor: even as we embrace new and exciting drugs and technologies, the time-honored medical tradition of compassion and active listening is the core of what we do. One of the things I love to do, as Dr. Gupta mentioned, is talk to mentees and to give talks to educate, which is why I usually say yes when somebody asks me. And then here are my mentees who I've been very privileged to work with, my funders, and thank you very much. And that was it. And we have some time for questions, which is great.
Wonderful. Thank you so much. There's a couple of questions in the chat, Dr. Mohile, if you could see in which order to address them.
Yeah, maybe I'll take the first one, which is a very important question related to disparities and thinking about recruiting people from diverse racial and ethnic communities, and how outcomes may be different between those populations and a white population. So we know health equity is super important, and it always has been important. But I think the national language and community has are adopting more the importance of looking at health equity and disparities. So just like we haven't done a great job of enrolling older adults into clinical trials, we have done even a worse job of enrolling older adults who come from backgrounds that are not white. So people who are Black, people who don't speak English, we've just done a terrible job. So in the trial, and I've done a terrible job personally. So in the trials that I had, there was less than 10% of patients from those backgrounds. And so I've made a commitment to myself and to my funders that we're going to change that with a survivorship grant we have open. We're translating all the methods into Spanish. We're working with stakeholders in the communities to enroll older adults to that survivorship grant who are intersectional in that they're more vulnerable due to their backgrounds and social determinants of health. And I'm working through the Cancer and Aging Research Group with rising stars who are from underrepresented backgrounds to do a systematic review of the literature in geriatric oncology. We're close to being done with that. It will be presented at the American Geriatric Society in May. And what we found is there's less than 40 studies that even ask a research question related to health disparities in geriatric oncology, which is really horrible. And most of those questions are related to epidemiological outcomes. So do patients who are Black have more of a prevalence of X disease? And it doesn't ask a real research question related to how do we improve care delivery or outcomes in these populations. And so we have a lot of work to do. And given that I'm more senior and I can do this work, it's not my expertise, but I, as much as possible, try to use the funding that I have available to support research endeavors in this area. And the hope is we're growing collaborations and investigators who are interested in that. I hope I was able to answer that question. And I'm sorry that I don't have more to report. Dr. Gilmore at University of Rochester has looked at some communication outcomes and is looking at medical mistrust using the coach data. And that data isn't published yet as much, but is seeing different relationships and communication outcomes. For example, older adults who are Black and fit, their fitness is under-recognized. Older adults who are Black and frail, their frailty is under-recognized. So if you're fit, you're less likely to be perceived as fit. And if you're frail, you're less likely to be perceived as frail. It's so weird, but it's just because people can't tell without an objective tool, which is bias. So the next question is, how do you approach otherwise very healthy geriatric patients? Oh, this is a great question. We occasionally see remarkably healthy but quite elderly patients, and choosing initial management can be worrisome, particularly in the curative intent scenario. And I've not frequently seen the use of a geriatric screening tool, so they may have significant cognitive or other issues, and that is true. So that is a great question. So I think the geriatric assessment tools can help in multiple ways for patients who are perceived to be fit or perceives themselves as being fit. So there are fit patients who want every kind of treatment and they want standard of care. And so a geriatric assessment can help identify those subtle things that will become more pronounced for someone who's over the age of 80 because of physiologic reserve. And so it provides a baseline that can be followed. So I have patients who I know their MoCA score is good, and I'm like, your MoCA score is good for your cognition, go get started. But then they come back 3 months later and they're having memory issues. Now I can repeat the MoCA score and I can see what happens with that score and communicate whether or not proceeding with treatment makes sense, which is very useful. And so very fit patients should potentially get standard care if that makes sense to them. But there are more risks for outcomes. Also, you may be perceiving some subtle issues that can be, dealt with, like polypharmacy issues, medication issues that older adults who are fit may be more prone to adverse outcomes for. I also have older adults who are fit who don't see themselves as fit. So they say, I'm 80 and I don't want any treatment because, I'm 80. So the geriatric assessment can actually help convince older adults who are going to be harmed by their cancer to get treatment, whether it's adapted or full. And so I use the geriatric assessment to say, well, you're 80, but you're quite fit. And if you decided not to get treatment, here's what might happen with the cancer and your longevity. And if you decided to get treatment, you might have these outcomes. And they would have more. I've been able to sort of encourage older adults to see themselves as fit and attempt treatment when I know the cancer is going to harm them. So that's another use of geriatric assessment for fit patients.
And there's, I think, a last question by Dr. Blaze.
Yeah, so this is a very good question. So how do we incorporate geriatrician or primary care doctor into these models? Oh, what a loaded question, Dr. Blaze, so hard. So it depends on what the setting is. So in Rochester, we're lucky that we have a wonderful primary care network and it's very cohesive. So in our clinic, it's a consultative clinic, because the consultative clinic, I can send the follow-up to the primary care doctors as well as the oncologist, and they'll adopt those results and act on them in our community in Rochester. So when we do a consult for the geriatric assessment, I'm not always providing the longitudinal care. I'm sort of putting all the context together, and I share that information to the busy primary care doctors who don't maybe have time to do the full geriatric assessment as well, and the oncologists. And they'll say, thank you, we'll take away that blood pressure medicine that doesn't make sense or has high risk, or thank you, we'll follow the cognition. I'm going to be more in tune of that. I've jumped in when people have needed more support because I have an academic clinic and I have the time to do it. We have frail couples who need more intense living situations, like they need to move out of their home. Sometimes that's so difficult. And so I will follow those patients. We have a wonderful geriatrics group in Rochester too, that is very busy and does not have capacity to take in all of the new patients that we have. And so engaging the primary care model is important in that community. In our national community, there's even more gaps. So Dr. Grant Williams published in a JOP paper that only 30% of community oncology settings have access to a geriatrician. I think it's very similar for palliative care. So I do think a lot of the burden will fall on us as oncology teams still, until there's more capacity in rural areas and there's not, more capacity for primary care in some of these areas. So it's really going to be resource setting that determines about how to engage with other teams. I found that most community oncology clinics have APPs per NCORE. And so you can use nurse practitioners, advanced practice practitioners, and I think they are key leaders in this movement. They are willing to be trained, they're willing to implement these models, and they're willing to be champions. And so that's how we're framing our survivorship trial.
Perfect. Thank you so much, everyone, for attending, and for Dr. Mohile for sparing your morning. I know you're meeting with a couple of our faculty later this morning, and have a wonderful week, everybody. Thank you.
Thank you, everyone. Goodbye.